Hi everyone, this is the EMT 200 overview of soft tissue injuries. Soft tissue, we're going to discuss everything from cuts and lacerations to penetrating trauma to bruises and burns, and how to recognize what's serious and what's minor, what to do about it, and what to assess and what to report. So soft tissue injuries are very common. I think everyone gets one routinely. Usually they're not serious, but they can be, and these can be dramatic and open wounds, and but not life-threatening. They may not bleed a lot. So these can be what's called a distracting injury, where we arrive on scene and perhaps the patient has an open wound with a lot of tissue and exposed to say someone's arm or leg, and so we see that, and when we sort of our attention's drawn to that, but they may also have a serious head injury or an airway compromise or something that is more pressing. So we want to be aware of them, that these can be life-threatening, but they may not be the most serious thing wrong with the patient initially. So soft tissue injuries can be blunt, they can be penetrating, they can be from barotrauma, and they can be from burns. Death from soft tissue injuries can either be from hemorrhage or infection. And we can prevent a lot of, we can stop bleeding, and taking care and dressing them can prevent the infection. So the skin is the body's first line of defense against infection and exertional forces. So it's the largest organ of the body, and it's tough but susceptible to injury. And our goals are to control bleeding, prevent infection, protect wounds from further damage, and apply dressing. So skin varies in thickness, and the very young and the very old skin is very thin, and it's more easily damaged than thick skin. The skin has two principal layers, the epidermis and the dermis. The epidermis is the tough outer layer, the dermis is the inner layer. The dermis is where there are hair follicles, sweat glands, and sebaceous glands. And blood vessel in the dermis is what provides skin with nutrients and oxygen. So skin keeps pathogens out, it keeps fluids in, helps regulate temperature, and nerves in the skin report back to the brain environmental sensations, which help us adapt to our surroundings. So any break in the skin may allow bacteria to enter, which could cause infection and fluid loss and lack of temperature control. So there are three types. There's closed, there's damage beneath the skin or mucous membrane, but the surface is intact. Open, where there's a break in the surface or mucous membranes and expose deeper tissues to contamination. And burns, which damage results from thermal heat, frictional heat, or toxic chemicals. So our primary goal is cessation of bleeding. So wound healing is a natural process with overlapping stages. First is there's a cessation of blood loss. So the blood vessels constrict, but this also, while it stops bleeding, it also hinders the nutrients from being delivered to the affected area, prevents the tissue's ability to eliminate waste, and can interfere with homeostasis. And the wound healing stage is inflammation, where cells move to the damaged area. White blood cells migrate to the area to combat pathogens that may have invaded the exposed tissues, and lymphocytes destroy the bacteria and other pathogens. And new blood vessels can form as the body attempts to bring oxygen and nutrients back to the injured area. There's new capillaries lie adjacent to the damaged skin. And then collagen provides stability to the damaged tissue and joins wound borders and closes open tissue. This is tough, fibrous protein. Is scar tissue. Is found in scar tissue, hair, bones, and connective tissues. But collagen will not restore skin to its original strength before the injury. So with closed injuries, there are contusions or bruise, which can cause bleeding beneath the skin, but do not break the skin. These are blunt forces, and the buildup of blood produces black or blue, discoloration or ecchymosis. Hematoma is when blood is collected within the damaged tissue in the body or cavity. This is when a large vessel is damaged and bleeds rapidly. This is usually associated with extensive tissue damage. So a crush injury occurs when there's a significant amount of force affected to the body. It depends on the severity, depends on how much force and the time that it was a force applied. And compression of the soft tissues will cut off circulation. which causes tissue destruction. And when it's trapped for more than 4 hours and blood flow is compromised, there's what's called crush syndrome. And when the patient's tissues are crushed beyond repair, muscle cells die, and they release toxins into the affected area. And then when the limb is freed, those substances can be circulated back to the body and cause dysrhythmias and electrolyte imbalances, and patients can actually die soon after an injured extremity is removed when trapped. So freeing the body part from entrapment also creates the potential for cardiac arrest and renal failure, and there's some measures that paramedics can take to mitigate that. So any patient with any crush injury you would want to notify ALS for. Something else that could be done is applying a tourniquet to a crushed extremity before it's removing them, and then that will that'll keep the toxins or limit the toxins from being moved into central circulation after it is freed. Another injury is compartment syndrome. This is when edema and swelling increase and create pressure and compromise circulation to the area distal to the injury. And they also cause toxins to build up. And the cure as treatment for this is actually surgically opening the wound to allow to relieve the pressure. So with open injuries, this is when the skin is damaged, wounds contaminated. There are abrasions, lacerations, avulsions, and penetrating wounds. And it's important to get the term right for documentation purposes. So an abrasion is a disruption of the superficial layer of the skin, also like a brush burn or a road rash after a fall from a bicycle or motorcycle. And these can be very painful because there's a lot of nerve endings towards the top of this, towards the epidermis. So a laceration is a jagged cut. This is from a sharp object or a blunt force that tears the tissue. So this is an incision is a sharp, smooth cut, while a laceration is a jagged cut. An avulsion is where layers of skin are separated. This may also be caused a degloving injury. And there's a flap of skin. These are especially distracting injuries when there may be another injury present, and there may be significant bleeding with this, or there may not be. And then an amputation is an injury which the body part is completely severed. So usually these amputations do not bleed very much because there's vasoconstriction. If there is bleeding, then we would want a tourniquet would actually be better than direct pressure. You may go straight to a tourniquet if there's bleeding from the amputation site because it's going to be difficult to apply direct pressure. There's also a penetrating wound from a piercing object, so like a bullet wound or a stab wound. And these are, there may be more damage than what we can see. Oftentimes stab wounds and gunshot wounds may not have major external bleeding, but the damage is internal. And there may be multiple penetrating wounds, so we want to identify all the wounds, want to count the number of injuries. And possibly want to try to identify what type of gun was used, but we don't want to delay treatment for that. And then blast injuries, there's a primary blast injury caused by the blast wave and the pressure change, the secondary blast wave, which is from the flying debris, and the tertiary blast waves when the victims are thrown from the injury. So closed injuries are more difficult to assess because we can't see the open injury. And so when we're doing that, we're looking for bruising, swelling, and deformity. So for open injuries, we want to cover wounds to the chest, upper abdomen, or back with an occlusive dressing. So anywhere that there's an opening for air, we want to put an occlusive dressing. And there may be a team member just assigned to control the bleeding. We want to assume that all open wounds are contaminated, and we want to use caution with sterile dressings. For small wounds without significant bleeding, and there's debris, we can flush that away with sterile saline or sterile water. Most of the time the hospital is going to clean this. If it's major bleeding, we're not going to worry about contamination at that point. They'll worry about that at the hospital. Our main goal is to stop the bleeding. So for abdominal wounds, there may be an open wound, there where organs are exposed, or an evisceration. the organs may actually protrude through the wound. So we want to cover that with sterile gauze, moisten with a sterile saline solution. So for this one, we would want the gauze to be moist. And then we would secure it in place with an occlusive dressing and try to keep the organs warm. So we want to avoid drying them out, and we want to avoid any air getting into the site. We have an impaled object, so we want to leave that in place unless it's impeding the airway. And we don't want it to move, we want to splint it in place. So neck injuries, not only are the neck injuries prone to bleeding a lot, but their air can also enter the wound and cause an air embolism, which could cause a stroke. So when we have a neck injury, we want to cover that with an occlusive dressing, even starting with your gloved hand, and then apply a pressure over the occlusive dressing. So the occlusive dressing, the goal is to prevent air from entering, and the pressure is to get the bleeding to stop. So we never want to apply pressure to both sides of the neck. If a patient has injuries on both sides of the neck, we would apply as little pressure as possible. We can apply more if the injury is only on one side, but we want to avoid doing it to both. Animal bites, even minor animal bites, are prone to infection. So we would want to, if a patient was trying to refuse to go to the hospital, we would want to strongly advise them to go because they're going to need antibiotics and a tetanus shot. Human bites are also prone to infection. So human bites are another reason that even if there isn't a serious bleeding, there's a strong potential for infection. So patients need to be evaluated for that. Okay, so burns are extremely painful and serious. And these occur when the body receives more radiant energy than it can absorb. The sources of of burns are heat. They can be from toxic chemicals or electricity. So burns or soft tissue injuries are created by the transfer of radiation, thermal, or electrical energy. And thermal burns occur when the skin is exposed to temperatures higher than 111 degrees. So the severity of a burn correlates with the temperature, the concentration, the amount of heat energy possessed by the object, and the duration of exposure. So the greater the heat energy, the deeper the wound. And people will reflexively move away from heat. Think about touching a hot stove, but they cannot do so if they're unconscious or they're trapped in, say, a fire. So the skin that acts as a barrier is destroyed. So this causes risk for hyperinfection, hypothermia, and hypovolemia and shock, because fluid will actually shift out of the vascular space towards the damaged area, and can cause a distributive shock. It will cause a hypovolemic shock as fluid leaves the vascular space. So the most serious complication of burns are airway burns. These can include the upper airway. Circumferential burns can cause tissue damage, can decrease circulation to the distal part of the extremity that's burned. Circumferential burns to the chest can also compromise breathing. So severity of burn depends on the depth, the extent, the area involved, pre-existing conditions, and age. So superficial burns involve only the top layer of skin. So a sunburn's an example, and this can be really painful because there are lots of nerve endings in the epidermis. And partial thickness burns or second-degree burns involve the epidermis and some of the dermis. And these cause blisters. They're also very painful. And full-thickness burns extend through all layers, which are destroy nerve endings. The area will be dry and leathery or charred. And the patient may have no feeling, that there may be little pain with this, although the area surrounding the full thickness burn is probably going to be a partial thickness burn, which will be painful. So the extent is the body area covered by the burn. And when we're looking at the area of burn, we're most interested in the partial thickness and the full thickness in estimation of burn. So we use a couple tools for that. One is the rule of palms. So an area, the patient's palm, an area that covered by the patient palm is about 1% of the patient's total body surface area. The other one is the rule of nines, which is used for adults. Children and infants have a modified version of that to estimate burn surface area. So our care is first to stop the burning process. If the patient is still burning, if they ran out of a house on fire or something, and if there's still a burning going on, we want to stop that. We want to use water to pour that and prevent additional injury. So thermal burns can be caused by scalds or an open flame. So children may pull the boiling pot on top of them. Flames may be involved with someone in a fire, or a contact burn from a hot object. A steam burn can produce a scald burn too. And this can happen with microwaving food covered in plastic wrap. And a flash burn is produced by an explosion. And this is a sort of a lightning strike as an example of this. A patient can be near a very intense heat for a very short period of time. So we want to remove any jewelry around the burned area, because we expect that it's going to swell, and then the jewelry may be stuck on the patient's skin. We want to apply dry dressings to any thermal burns. And the reason for that is if we can stop the burning process, and even if the patient feels better with fluid poured over the burn, we're at risk for hypothermia. So we need to maintain their body temperature. We need to keep them warm and use dry sterile dressings to cover the burns. And they have commercially available burn kits. So inhalation burns are especially concerning because these can cause edema in the upper airway. So these are inhalation of superheated gases. And then there can be lower airway compromise from chemicals or particulate matter. So you see upper airway swelling. This is something you need paramedics for. The patient may need a surgical airway. So we're looking for a stridor, a hoarse voice. We see singed nasal hairs, any kind of facial burns or any carbon particles in the sputum if the patient's coughing up dark secretions. So we want to administer high flow oxygen, prepare to assist ventilation, and we would want to get the patient as hospital as quickly as possible and request paramedics. So chemical burns occur whenever a toxic substance contacts with the body. It's generally strong acids and strong alkalis. The eyes are vulnerable to this, and the severity replaces the chemical, the concentration, and dilution. And we want to make sure that these patients are decontaminated before we take care of them. So we're going to remove a chemical. To remove the chemical if it's powder, we're going to brush as much as we can off and then flush it with water. We don't want the water to sit on the patient's skin because it could make the burning worse. For liquid chemicals, we're going to flush because we want the water to move away. We're going to do this for 15 or 20 minutes. If the patient's eye has been burned, we can use a device called a Morgan's lens or eye wash station. And electrical burns are the result of contact with high or low voltage electricity. So for electricity to flow, there must be a circuit between the source and the ground. So an insulator is any substance that prevents the circuits, and a conductor is a substance that allows the current to flow. The human body is actually a good conductor, and then the body will complete a circuit from the power source to the ground. So the electricity will actually flow from the power source to the ground, and it will burn and cause damage on everything in that path. So it's very hard to predict injuries from an electrical burn. Patients can have fractures, they can have serious internal injuries. We want to make sure that they are, before we approach the scene, we want to make sure that they are away from the electrical source and that the scene is safe. So there may be a deep tissue injury, and then the patient may go into cardiac arrest from the electrical shock. And there are maybe 2 sites of external burns, the point where they came in contact with the electrical source and the point that came in contact with the ground. And we're going to treat the burns the same way we would a thermal burn, and keeping in mind that there may be internal injuries as well. For burns, we want to transport to a trauma center, the highest available local trauma center, unless there's an airway compromise. Then you may want to transport to the closest hospital to manage the airway before transfer. There are hospitals that are designated burn centers. In Delaware, the closest burn center is Crozier, and otherwise the University of Maryland in Baltimore is also a burn center, and Temple is the next closest burn center in Philadelphia. But burn care is secondary to the trauma care, so we want to get them close to the closest available trauma center, and after they're stabilized, burn care is a long-term process. so the patient can be transferred after their traumatic injury is managed. So to dress soft tissue injuries, all wounds, we want to bandage all wounds. There's different sizes. Some are sterile, some are not sterile. There's 4x4, 2x2, and 5x9 dressings. There's the abdominal dressing, which is also known as the oh my gods, and there are occlusive dressings that keep air out. And then there's cling or roller gauze. They're 2-inch roller gauze, 4-inch roller gauze, and then we have the Israeli dressing, which is a pressured bandage. So anytime we bandage the wound, we want to make sure that the limb distal to the bandage has circulation. So we're going to check capillary refill, pulse, motor, and sensory distal to the area. And that is the overview of soft tissue injuries.